Hello guys, good evening. Can you all see me? Can you all hear me? Can you all see me? Can you all hear me? Quick feedback. Hi guys, good evening, good evening. So today we're going to start a new topic, and that is going to be quite important, and it's going to be quite interesting also. I hope everybody is joined in, tuned in. Right, today's topic is going to be a little bit more exciting, more interesting, and obviously for lot many reasons it's going to be a lot more exciting as well. If you have any suggestions before we start the session, I'll be open for that. Quick feedback. Can we start? Right. So our objective from today onwards is to talk about hernia. Right. A very, very interesting and an important topic, but we'll try to decode it as we go. Now, hernia is something we all understand. It is a protrusion of the abdominal viscera through an anatomical weakness in the abdominal wall. It's as simple as that, right? It's an protrusion of an abdominal viscera, or I can say cavitary viscera, through a abdominal wall weakness, or it could be in some ways in thorax also. It's a thoracic wall weakness, but we'll restrict ourselves to abdominal wall, right? NVK, I think we have announced, we start with hernia and then we build on GIT. That caused the basis of it. Okay. Chal. Now, yeah. Okay, got it. So as I told you, we'll be continuing from hernia onwards, right? Now, in order to understand hernia, you need to have a very sound knowledge of abdominal wall. So let's quickly talk about the abdominal wall's anatomy, and then we'll see the inguinal canal's anatomy, and then we'll build up from there. So when we talk about the abdominal wall, from outside to inside, we'll try to see across it, right? Now, when you look at the outermost structure, let's say this happens to be the skin. So I'm just representing in white. So this is probably a gora, right? So under the skin, what do you have? You have the subcutaneous fat. The subcutaneous fat is divided into two layers. It is going to be the campus and the scarpa. So the outer layer is going to be the campus layer, and below the campus you will see a fibrous layer, or I guess a sheety layer that is present. This is what we call the scarpas, right? So the subcutaneous fat is divided into two layers, that is the outer campus and the inner scarpa, right? Next you have the abdominal wall muscles, right? Which course in developed stomach hernia? Santosh, I didn't get your question. Fine, anyhow. So this is how the abdominal wall starts with the skin, then the subcutaneous fat into campus and scarpa. Then you have the abdominal wall muscles. Now you have two distinctive abdominal wall muscles. One which is going to be on the lateral side, we call it as the lateral abdominal wall muscle, and one that will be present in the midline will be called as the central abdominal wall muscles. Now when talk about lateral abdominal wall muscles, you have the external oblique muscle, you have the internal oblique muscle, and you have the transverse abdominis muscle. The three muscles which forms the lateral abdominal wall. Now external oblique muscle fibers, they will be pointing inwards as if you are putting a hand in your pocket. Your internal oblique muscles fibers run as if you are taking the hand out of your pocket, so opposite to that of internal oblique. Transverse abdominis muscle fibers, they run transversely. Your transverse abdominis muscle fibers, they run transversely. So you have the external oblique muscle, the internal oblique muscle, and the transverse abdominis. The same set of muscles will also be seen on this side. This is your external oblique muscle. This happens to be your internal oblique muscle, and this happens to be your transverse abdominis muscle. So based upon the orientation, you can see the oblique muscles have an oblique orientation. The oblique muscles are going to have the oblique orientation. So this is how the muscle fibers of the external oblique is, and this is how the muscle fibers of the internal oblique, right? So they're crisscrossing each other and they're flowing in a different direction. And this is how the muscle fibers of the transverse abdominis muscle is, right? Now right in the center, you have the rectus abdominis muscle. Right in the center, you have your rectus abdominis muscle, right? So from the lateral side, you have your external oblique, internal oblique, and transverse abdominis. Let's label them as we move across, right? So the outermost layer that we came across, this is going to be the skin. Next to skin, you have the Camper's layer. Then you have the scarpa. This is your external oblique muscle. This is your internal oblique muscle. This happens to be your transverse abdominis muscle, right? So three muscles. You have the external oblique muscle, the internal oblique muscle, and the transverse abdominis muscle. This happens to be the rectus abdominis muscle. On the either side, you have a pair, that is your rectus abdominis muscle. Now, when you look at the entire context, you will see all these muscles, no, they will be lined by the aponeurotic tissue. When two muscles, they are going to merge in one particular side, you will have the aponeurosis, which is going to continue from the muscle so that it allows it to merge easily. Now, when you look at the external oblique muscle, this is your external oblique aponeurosis, right? So this is the external oblique aponeurosis which is present. So use the same color on the either side. This is the external oblique aponeurosis. Now, after the external oblique aponeurosis, let's say this happens to be your internal oblique aponeurosis. The internal oblique aponeurosis has two leaflets, the anterior leaflet and the posterior leaflet. So this is your internal oblique aponeurosis. The internal oblique aponeurosis has two leaflets, the anterior and the posterior one. They have the two leaflets, that's the anterior and the posterior one. They have two leaflets, the anterior and the posterior one. Then you have the transverse abdominis, and let's say this happens to be the transverse abdominis aponeurosis. This happens to be the transverse abdominis aponeurosis, right? So you see the three aponeuroses that we have done, the external oblique, the internal oblique, and the transverse abdominis. What you will notice is the external oblique aponeurosis and the anterior part of your internal oblique aponeurosis, they are going to merge together. They are going to merge together. Now, once they merge together, they form the anterior rectus sheath. So once they merge together, they form the anterior rectus sheath. The posterior border, look at the posterior border. We'll use a different color here. What can we use it? I need some light color. Okay. Okay. So the posterior border and the transverse abdominis aponeurosis together form the posterior rectus sheath. Together it forms the posterior rectus sheath, and in the midline they are going to fuse together. Right? Smriti Panda, which book to read in the final year for the surgery which has easy to understand language? Beta, the only book that I recommend is Bailey and Love. I know थोड़ा पढ़ने में दिक्कत है, इसीलिए हम ये सीरीज बना रहे हैं. Now whatever अभी मैं आपको जो समझा रहा हूँ ना, ये जाके आपको बस वापस बुक में पढ़ना है. All that you have to do is whatever I am right now teaching you, ठीक है? Just listen to this, go open your Bailey, start reading the abdominal wall. You'll just finish just like that. ठीक है? Let's work a little bit. I know that initially थोड़ा वो resistance है to to start watching it or start looking at it. It's slightly different and difficult, but after that, trust me, it is going to be super easy, right? So the BLS lectures are adjuvant to our Bailey's textbook. Whatever we are teaching here, all that you have to do is to go back, open it, textbook again, and try to put a little bit of effort there. Okay? Now, let's come back to our lecture. So you have all these aponeurotic tissues. So I'll just quickly label them. This is your external oblique aponeurosis. This happens to be your internal oblique aponeurosis. This is your internal oblique aponeurosis. This is the anterior leaflet. This is the posterior leaflet. And this is a transverse abdominis aponeurosis, right? So external oblique aponeurosis, internal oblique aponeurosis, anterior leaflet, posterior leaflet, and the transverse abdominis aponeurosis, right? So all these are aponeurotic tissue. When they merge together, this is where they form the anterior rectus sheath. This is what the anterior rectus sheath, and this is the posterior rectus sheath. This happens to be your posterior rectus sheath. Now you know what is the anterior rectus sheath and what is the posterior rectus sheath, right? What is the question, beta? Whole course will be completed or not? Smriti, the objective and the goal is to complete the entire Love and Bailey textbook. I am trying to be consistent, trying to come 3 days a week. If we remain consistent, I think we should be able to finish by the end of this year. We will. Okay? So don't worry about it. Just follow. See, we have already done 36 hours of lectures. Already BLS आज 37th episode है. Okay? So we've already done 36 hours. You go, by the time you finish those 36 hours in your book, no, already another 36 hours would have been added. So trust me, whatever series that we are running right now is enough for you to go back, read your Bailey, understand it. If you have doubts, come back to the video lecture here. And this, we're doing it in a very elaborate fashion. I'm pretty sure you're not going to miss on it. Okay? Chalo. So let's not deviate from the present context. Let's quickly run through it. So from the abdominal wall, you have the skin, campus, scapa, external oblique, internal oblique, transverse abdominis, aponeurotic tissue, external oblique aponeurosis, and the anterior leaf of the internal oblique aponeurosis form the anterior rectus sheath. The transverse abdominis aponeurosis and the posterior leaf of your internal oblique aponeurosis together form the posterior rectus sheath. Now, once all the rectuses are in their position, then comes the fascia transversalis. So we have this big guy who's going to come now. He is your fascia transversalis, and this fascia transversalis is going to run throughout the abdominal wall. Now, just below the fascia transversalis, you have the peritoneum. So this is the peritoneum. The innermost is going to be peritoneum, and below that you have the bowel, right? So when you look at this context, so this is your fascia transversalis. This is your fascia transversalis, and the last layer is the peritoneum. And once you breach the peritoneum, this is your intra-abdominal cavity. This is your intra-abdominal cavity, right? So if somebody asks you that how would you reach into the abdomen? How would you get into the abdomen? Your question would be, shall I start from the lateral side or shall I start from the medial side, right? So if you start from the lateral side, it is going to be skin, campus, scapa, external oblique, internal oblique, transverse abdominis, fascia transversalis, peritoneum, and then here. Now, between the fascia transversalis and peritoneum, there is a pad of fat that is going to be present. And this layer which is present is called as preperitoneal pad of fat. This is what we call it as the preperitoneal pad of fat. This is defined as the preperitoneal pad of fat, right? This is what we call it as the preperitoneal pad of fat, and that is where the distinction between the fascia transversalis and the peritoneal layer is going to be present. Clear, right? If you understand this picture representation, now you understand the abdominal wall from the lateral and as well as the midline, right? So from the lateral side, when you look at it, it is going to be skin, campus, scapa, external oblique, internal oblique, transverse abdominis. Then you have fascia transversalis, preperitoneal part of fat, and peritoneum. When you start from the midline, skin, campus, scapa, anterior rectus sheath, then you have rectus abdominis, posterior rectus sheath, then you have the fascia transversalis, then you have preperitoneal part of fat, and then eventually you're going into the abdominal wall, right? So this is all that you should know in the context of the orientation of the abdominal wall. Now, when you look the abdominal wall in a whole context, right? So if I give you an abdominal wall, this is how the representation of the abdominal wall would look like. This is how the representation of the abdominal wall would look like. Now, I'll have two important points that I'll be marking. One is going to be the Ziffy sternum. Another one is going to be your pubic symphysis. So Ziffy sternum and the pubic symphysis. Let's say this is the umbilicus that is present. You will notice that the rectus abdominis muscle which is present, it will start from the Ziffy sternum and it is going to go all the way to the pubic symphysis. all the way to the pubic symphysis, right? Now, if you look at the whole orientation of the muscle, the tendinous insertions that are going to be present here will form your classical six-pack appearance, and this is your rectus abdominis muscle. This happens to be your rectus abdominis muscle. This happens to be your rectus abdominis muscle, right? This happens to be a rectus abdominis muscle. On the lateral side, the muscle that we have, the orientation of the muscles which are present, the orientation of the muscles which are present on the lateral side, these are your lateral abdominal wall muscles. So this is your lateral abdominal wall muscle, right? So this is what I'm shading right now is the lateral abdominal wall muscles. So this lateral abdominal wall muscle, well, let's keep it simple. So this happens to be your rectus abdominis muscle. This happens to be the rectus abdominis muscle. And right next to the rectus abdominis muscle, this is your lateral abdominal wall muscle. This is going to be your lateral abdominal wall muscle. This is going to be the lateral abdominal wall muscle. Just for the sake of understanding, I'm just going to highlight this. This is your lateral abdominal wall muscle. This is the lateral abdominal wall muscle. So you have the rectus abdominis muscle. So this is your rectus abdominis wall muscle, and this happens to be your lateral abdominal wall muscle. Lateral abdominal wall muscle. Now, why I'm being so precise about it is you need to understand that two lines which are going to be formed here. Now, the first line which goes right dead in the center. There's a line that is going to go right dead in the center. This is what we call it as the linea alba. And there's another line which is going to be slightly curved here, and this is what we call it as linea semilunaris, right? So there are these lines that we need to understand. One is your linea semilunaris. One line is your linea semilunaris. Another line is going to be your linea alba. Another line is going to be linea alba. So what is this linea semilunaris? What is this linea alba? Come back here. Now you can see the junction where your lateral abdominal wall muscle is meeting the medial abdominal wall muscle. This line is what we call it as the linea semilunaris. This dotted line is a linea semilunaris. The line that passes right into the center of the rectus abdominis muscle, this is what we call it as the linea alba, right? So linea semilunaris is the junction between the lateral and the, that is lateral abdominal wall muscle and the rectus abdominis wall muscle, whereas the linea alba, which is going to be where the two rectus sheaths are going to meet, right? Both the anterior posterior rectus sheath, they meet in the midline, that is your linea alba, right? So now you know what is linea alba, what is linea semilunaris. So these, you know, the line clarity you need to have, right? Now once you have this, let's dig in a little bit more with respect to your posterior rectus sheath. So there's a small variation in your posterior rectus sheath that you need to understand. Now you take this as a representation of Ziphi sternum, right? And let's say this happens to be our pubic symphysis. This is the pubic symphysis. We all know the rectus abdominis muscle is going to be between the Ziphi sternum and the pubic symphysis, and this is the orientation of the rectus abdominis muscle. I'm just giving you one section. This is your rectus abdominis muscle, right? Now you have the anterior rectus sheath and the posterior rectus sheath. The anterior rectus sheath starts from the Ziphi sternum, covers the entire rectus abdominis muscle, and attaches at the level of your pubic symphysis. Okay? It is continuous with the entire rectus abdominis muscle. The posterior rectus sheath, on the other hand, starts from the Ziphi sternum. It continues. It goes all the way, right? So if this is the representation of the skin, and let's say this is the umbilicus, and this is the skin which is covering, and this is the line where the umbilicus is going to be present. This is the line where the umbilicus is going to be present, right? Now from the umbilicus, you come around 2 centimeters below. 2 centimeters below the level of umbilicus. 2 centimeters below the level of umbilicus, the posterior rectus sheath starts to pierce the rectus abdominis wall muscle, becomes anterior, merges with your anterior rectus sheath and combines it. Right? Now you see the posterior rectus sheath does not cover the entire rectus abdominis muscle. 2 centimeters below the level of umbilicus, it pierces the rectus abdominis muscle and then it becomes anterior. Now the point where it is happening, where the posterior rectus sheath is piercing the rectus abdominis wall muscle and becoming anterior, this is what we call it as the arcuate line. This is what we call it as the arcuate line, right? So line from where the posterior rectus sheath becomes anterior, no, that exact origin is what we call it as arcuate line. It is usually seen 2 centimeters below the level of umbilicus. As simple as that, right? Then there's a confusion, what is a Spigelian fascia? Because lot of you have a confusion that saying, sir, Spigelian fascia and the arcuate line, are they one and on the same? They are not. Now, when you look at the representation, again, let's say this is the abdomen which we are going to represent. So every time we draw the abdomen, we'll be drawing the abdomen in this particular manner, right? Now, let's say this happens to be the umbilicus dead in the center. And let's say this happens to be the rectus abdominis muscle. So this is how the rectus abdominis muscle is going to be present. Then you have the lateral abdominal wall muscle. You see the lateral abdominal wall muscle flows with the same contour and it goes like this. So this is your lateral abdominal wall muscle, and rather than taking the shape of the rectus abdominis, in the lower part, no, it slightly varies off. Now, where does it vary? You can see there is a small junction, there is a small area between the rectus abdominis muscle and the lateral abdominal wall muscle, which is not covered by any muscle. So this is actually an area of anatomical weakness which occurs at or below the level of arcuate line, right? This is what we call it as the Spigelian fascia. So what is this Spigelian fascia? There's a lot of buzz around it. What is this Spigelian fascia? What is this Spigelian fascia? Kuch nahi hai Spigelian fascia. Spigelian fascia is that area of the abdominal wall which is not covered by abdominal wall muscles, right? The rectus abdominis is right here. The lateral abdominal wall muscle comes, but there is that area where none of these muscles are covering. The area where none of these muscles are covering, this area is covered by a small fascia, and that is what we call it as Spigelian fascia. And if the hernia arises through this area, it is called as Spigelian hernia. As simple as that, right? So when you look at this, this is a very simple concept that this is the lateral abdominal wall muscle. Lateral abdominal wall muscle, it is not going to contour or completely merge with the rectus abdominis. This is how the lateral abdominal wall muscle is going to be present. So the area which is going to be present, so when you look at this, the area between, so this is the lateral abdominal wall muscle which is present. This is the lateral abdominal wall muscle, and you see that this happens to be your rectus abdominis. So there is this area between the rectus abdominis. This is area between the rectus abdominis and the lateral abdominal wall muscle, which is not guarded by any muscles. This is what we call it as the Spigelian fascia. This is what we call it as the Spigelian fascia. So this is the fascia. This is a small fascia where you have the lateral abdominal wall muscle. Just for the sake of understanding, these are your lateral abdominal wall muscle. This is your lateral abdominal wall muscle, and right in the dead center you have rectus abdominis muscle. Clear? Okay. So do not make a mistake of misunderstanding the Spigelian fascia and the Spigelian fascia, right? So now we have a sound understanding of your abdominal wall. Voice is breaking. Why is the voice breaking? But I am on a perfect battery also. The internet connection is also fine. Hi Osama. Is anyone else now facing any issue with the voice? A quick feedback, please. Can you all hear me? Can you all see me? Can you all hear me? Can you all see me? Quick feedback. ठीक है, कंटिन्यू करें? Can we continue? Now fine. Voice, no issue. Ashutosh says no issue. Smriti says voice is breaking. Beta, I think your internet has an issue. Kindly refresh. Kindly refresh. Kindly refresh. Okay, chalo. Now, so we now know the entire concept of the abdominal wall. Now to understand the hernia, we'll start with the basis of inguinal hernia. तो अपना काम है inguinal hernia के साथ शुरू करने के लिए. But before that, you should know that where else you can have the origin of hernias. So we'll talk about various hernias and their presentations, right? So in general, we'll see what are the sites where this hernia can develop, right? So when you look at the entire context, let's say this happens to be the thoracic and the abdominal cavity. This is going to be the pelvis, and this is going to be the groin area, right? Just for the sake of understanding, this happens to be your anterior superior iliac spine. This is the pubic symphysis. This is the pubic tubercle, pubic symphysis, and this happens to be your pubic bone, right? So this is the orientation that you need to keep. So again, you have the pubic symphysis, the pubic tubercle, the pubic rami. You have the anterior superior iliac spine, and this is the pubic bone that we have, right? This is the orientation that we have to keep, right dead in the center. आशुतोष बेटा ट्रायंगल ऑफ पेन, ट्रायंगल ऑफ टूम तब बताएंगे जब आपको लैप्रोस्कोपिक इंग्वाइनल हर्निया बताएंगे, ठीक है? अभी के लिए कीप एन आई ऑफ व्हाट वी आर टीचिंग राइट नाउ, ठीक है? सो डोंट ओवरफ्लो आवर कोर्स, ठीक है? तो you will see this is the umbilicus which is present. This happens to be your Ziphy sternum. This happens to be the Ziphy sternum. This happens to be your linea alba. We just learned this happens to be your linea alba. This line is your linea semilunaris. This is your linea semilunaris. This will be your inguinal canal. This will be your inguinal canal. Just for the sake of understanding, I've given you all the important sites. Okay? Now, let's see what are the sites where the hernias can develop. Right? One, the hernia can develop here. One, the hernia can develop here. One, the hernia can develop here. So 3 groin hernias that are possible here. Right? Then you can have hernia developing here. You can have hernia developing from here. Hernia developing from here as well. Right? Then you can have on the posterior surface. On the posterior surface, you can see the hernia can sac out like this as well, right? So there's one possibility of having a sac developed or coming from this area. This is one form of hernia that you have. Let's say patient underwent any previous surgery. So there's a previous surgical incision that is present. There's a possibility that the hernia will also pop out from here. There's a possibility the hernia will also pop out from here. Now, if you take this as a representation, I'll just realign the umbilicus. Let's say this is the umbilicus that we're talking about, and let's say the hernia is popping from here. So this is the hernia that is here. Okay? So there's a possibility of hernia that is going to come from here as well. Okay? So these are the usual sites of hernia. You're like, what is all these sites? Kya kya bana rakha hai? Don't worry, I'm there for you, so we'll sort it out. Okay? Now when you look at this, the first hernia that you can see right in the groin, but above the level of your pubic symphysis, or I can say above the level of your pubic tubercle, this is what we call it as the inguinal hernia. This would be called as your inguinal hernia. Then comes just below it, but in the same groin region, this is your femoral hernia. This happens to be your femoral hernia. And if you go onto the medial aspect of the upper thigh, this is what we call it as the obturator hernia. So 3 hernias that can arise from the groin region. One is going to be your inguinal hernia. Okay, med student, I got the point. Somebody has suggested that there's probably some issue with the relay. You have to put your volume at the maximum so that you'll be able to hear the best. Okay? Yeah, correct. Obturator hernia is also called as the little old lady's hernia. Absolutely correct, Ashutosh. Good. Now, when you come a little bit on this side. This is what we call it as the lumbar hernia. This is what we call it as the lumbar hernia. Then you can see below the level of umbilicus. So this is what we call it as the hypogastric hernia. This is what we call it as the hypogastric hernia. Now, which is present below the level of umbilicus along the linea semilunaris. This is what we call it as the spigelian hernia. This is what we call it as the spigelian hernia. Now, one that arises from the umbilicus, this is your umbilical hernia. I am glad to inform you that there is no term called as para-umbilical hernia now. Now, umbilical and para-umbilical merged together is umbilical hernia. Okay? Baat hi khatam kar di. Okay? Now, one that arises from the previous incision, one that is arising from a previous incision, this is what we call it as the incisional hernia. One that arises from the previous incision is what we call it as incisional hernia. And one that is present here, this is what we call it as the epigastric hernia. This is what we call it as the epigastric hernia. In fact, the epigastric hernia, the umbilical hernia, and your hypogastric hernia, right? Whichever is present in the midline, this one, and this one. All three of them is what we call it as commonly as ventral hernias, right? So whichever is present from the Ziphy sternum to pubic symphysis in the midline, they are called as the ventral hernia. Ashutosh, don't run ahead. We'll talk about the sportsman hernia. It's a special variant in the inguinal region. It is not because of the defect. It is because of a tear of a muscle. We'll talk about it. Okay? Chalo. So these are the various sites where the hernias can develop. If you ask from a clinical perspective, which among the following is the most common hernia overall? The most common hernia overall, whichever you have discussed, is going to be your inguinal hernia. Now, this is always an incomplete answer because inguinal hernia are of two types. You have the indirect inguinal hernia and the direct inguinal hernia. Remember, it is of indirect variety, which is more common when compared to direct. And this is what they keep asking you in your NEET exam, in your INI-CET, all these exams, they just make a huge fuss out of it. It's quite simple. Now, if I ask the question and I change it, what is the most common hernia in females? Anybody wants to pick a point here? The most common hernia in females overall. Remember, the most common hernia in females is going to be same. That is going to be inguinal hernia, that too of indirect variety. Okay? Med student, you're absolutely correct, right? Now, if I change the question and I ask you, femoral hernia is more common in. Femoral hernia is more common in females when compared to males. Femoral hernia is more common in females when compared to males. Okay? So this is the baseline data that you should know. So never make these mistakes, and when you write a competitive exam, these are the questions which will just tangle you around. Okay? As simple as that. Now, let's start our discussion on inguinal hernia. So I'll be opening the discussion on the hernias with a very, very basic topic, that is a inguinal hernia. Now again, as we commence into the topic, I do not want you to mug even one single point. Every single point I will try my best to explain you. If you do not understand, it is your job to stop and ask again. Okay? Now let's say we need to understand the anatomy of the inguinal canal. So I will start with the anatomy of the inguinal canal. We'll start with the basic anatomy of the inguinal canal. Now, to understand the inguinal canal, let's say this happens to be your anterior superior iliac spine, pubic rami, pubic tubercle, pubic symphysis, and this continues to form your pubic bone, right? So this is the basic orientation of the pubic bone that I've given. Just for the sake of understanding, this is the midline. So to tell you that this is your linea alba. This is your linea alba, right? Now we'll start with each individual muscles and then we'll continue to go across it. We have initially used the color codes and we'll continue to use the same. So you have pink, green and blue. If I forget, do let me know. Okay? Now, the external oblique muscle is going to be here. So this is where the external oblique muscle is going to be present. So this is the orientation of the external oblique muscle. Now you need to understand that external oblique muscle, as it nearing the rectus abdominis muscle, as it nears the rectus abdominis muscle, this external oblique muscle will now start to form its aponeurotic tissue. It will now start to form its aponeurotic tissue. So this is your external oblique muscle which is present. And this external oblique muscle, let's say this is the rectus abdominis muscle. Just for the sake of understanding, we're just drawing it. This is the rectus abdominis muscle that is present. So what happens is it forms an aponeurotic tissue and then it merges with the rectus abdominis muscle. Now all this aponeurotic tissue which is formed, one, it is going to merge with the rectus abdominis muscle, but inferiorly what is going to happen? Inferiorly, you see that this aponeurotic tissue is going to attach to the anterior superior iliac spine and then form a tuft of band attached to pubic tubercle, and together they form across here. So this external oblique aponeurosis, which is condensing as a band, this is what we call it as the inguinal ligament. Now what is so beautiful about this is, the minute it comes to the pubic tubercle, it is going to arch backwards. So you will notice the minute it is going to come across here, the minute the external oblique aponeurosis comes here, and this is going to arch backward like this. So there's an attachment here and then it just arches backward. Now this backward arching, now you can see this is forming a tuft of band. If I'm just able to highlight this a little bit more, this tuft of band that is formed here, this is your inguinal ligament, and this curve, as it turns, it is forming a small opening here. As you can see, it is forming a small opening here, and this opening which is formed here, this is what we call it as the superficial inguinal ring. That's it. This is your superficial inguinal ring. Now behind the external oblique, so हमारी पहली muscle क्या होगी? This is your external oblique muscle. This is your external oblique aponeurosis. So A stands for the aponeurosis. This is your external oblique aponeurosis. Okay? Now, what is the next muscle that you have? The next muscle is going to be the internal oblique muscle. And the internal oblique muscle, let's say this is the orientation. I'm just going to give you, this is the internal oblique muscle that is going to be present. So this is how the internal oblique muscle and its aponeurotic tissue will be present. So this is your internal oblique muscle. After the internal oblique muscle, what was the third color code that we kept here? Okay, the blue. So after the internal oblique muscle, this is going to be the transverse abdominis muscle. So the innermost muscle that you have is your transverse abdominis muscle. The innermost muscle that we have is your transverse abdominis muscle. So you have the external oblique muscle, internal oblique muscle, and the transverse abdominis muscle. All of them are going to be present here. Now the beauty of this is, you will notice that all these muscles, when they come to the rectus abdominis, they're only able to cover this area. But this area which is behind the, that spigelian fascia wala area, right? That area which is like where the external oblique is going like this, the internal oblique is going there, the transverse abdominis is going, there's a small area which is left behind. That area is not guarded by any one of them except for one big fellow which is going to be flowing throughout. And that big fellow which is flowing throughout is going to be, what is this? This is your fascia transversalis. So this fascia transversalis is going to be continuous. The fascia transversalis is going to be continuous even on the posterior aspect. The fascia transversalis is going to be continuous on the posterior aspect. So when you look at this when you look at this entire context, just for the sake of understanding, I don't want you to goof up. So we'll keep it quite simple so that you understand it. So this is the superficial inguinal ring which is formed by external oblique aponeurosis. The posterior most structure, we'll remove this also, just like it's creating a little bit of confusion. I'm not liking it. Right? So the posterior most structure is going to be a fascia transversalis. So if you look at the dissection part, so this is the muscle that is present, right? So if I just label all the muscles that we have just drawn, this is your external oblique muscle. This happens to be your internal oblique muscle. This happens to be your transverse abdominis muscle. And the innermost is your fascia transversalis. It's a fascia transversalis. The innermost that you have is fascia transversalis, and inside the fascia transversalis, obviously we know that there is the peritoneal, that is pre-peritoneal pad of fat and peritoneum is present, but this is the basic concept that is present, right? So this you can see, this is your superficial, this is your superficial inguinal ring. This is your superficial inguinal ring. Now this condensation that is present, this is what we call it as, this condensation that you're able to see, this is what we call it as the inguinal ligament. This is what we call it as the inguinal ligament, and we all know inguinal ligament is attaching from this point. No, this is your anterior superior iliac spine, and this point which is attaching, this is your pubic tubercle. If you want to know a little bit more in terms of the beauty of the anatomy, the same inguinal ligament from the pubic tubercle, it is going to turn backwards. Now as it turns backwards, it attaches like this. Now this is going to attach like a fan structure, like a fan shaped structure. So it just pulls across like this, and this pulling is what we call it as lacunar ligament, and then it continues like this, and this is what we call it as Cooper's ligament. Bas naam hi badala hai aur kuch nahi kiya. Nothing they have done, just change the name. So this inguinal ligament, when it continues, attaches to the pubic tubercle. Pubic tubercle ko jab lag ke ye attach hoke piche ki taraf ghum raha hai na, as it turns backward, this is what we call it as the lacunar ligament. This is what we call it as the lacunar ligament. And this extension of this lacunar ligament is what we call it as your Cooper's ligament. This is what we call it as the Cooper's ligament. And there's a thin fibrous septa which is present here. And what is going to happen? This small ring that is formed, this is what we call it as the femoral ring. ठीक है, इसी को नाम दिया हुआ femoral ring का. तो आप देखो superficial inguinal ring यहाँ पे है, femoral ring यहाँ पे, they're very close to each other, right? So this is how the whole orientation is going to look across. The story is not finished, my friend, yet. You have to wait. ठीक है. Now this is only the first half of the, no, अभी तो interval भी नहीं हुआ. So इसको थोड़ा ऐसे साइड कर दो, ठीक है. Now, this is about the abdominal. Now, what I'm going to do is, I'm going to remove the external oblique, internal oblique, and the transverse abdominis. ठीक है, इसको देख के निकाल के देखते हैं क्या होता है. Now, you need to understand. I hope everybody is able to get the idea. I'll just, if you're not able to get the idea, I've gotten something for you so that we'll be able to use it. ठीक है. So we'll be using the same color code. This is 1. I'm going to take it in. ठीक है. So what is going to happen is, if you take this as a representation of the external oblique aponeurosis, ठीक है. Now external oblique aponeurosis, on one end it is going to attach to the anterior superior iliac spine, other end it is going to attach to pubic tubercle. Once it attaches, no, it is going to turn on itself. ठीक है, ये ऐसे करके ना U-turn मारता है. Now as it turns on itself, you notice जैसे ये turn करेगा ना, just give me 1 second. I'm not that great at origami, but I'll try for you guys. ठीक है. अच्छा. Now what has happened is, this is your external oblique aponeurosis. It has turned on itself. जब ये turn कर रहा है, it has turned like this. Now you can see, ठीक है. It has flipped on itself. Now this turn on itself, it has turned back on itself. Now this opening that you can see here, just because of this which is created, this is your superficial inguinal ring. तो basically canal की तरह बन गया ना. अब ये जो नीचे टिफ हो गया ना, now you can see it is double. You know, it's ये मोटा हो गया ना. It is becoming bigger, it is becoming thicker, right? This thickness is what we call it as the inguinal ligament. Inguinal ligament कुछ नहीं होता. ये external oblique aponeurosis, when it turns backwards, no, it becomes double layered, and as it becomes double layered, it becomes more stronger, and that stronger is what we call as inguinal ligament. और ये जो पीछे flip करता है, this flipping backwards is what we call it as your inguinal canal का start. तो ये जो entry हो गया, ये आपका, what is this? Superficial inguinal ring. Now, if you have external oblique here, what is the next muscle that you have? So we had 3 muscles, no? So we had 3 muscles, all 3 of them will be here. This is your external oblique muscle. Then this is your, what is that? Internal oblique muscle. After the internal oblique, what do you have? You have the transverse abdominis muscle. Okay? The 3 muscles which are present are external oblique muscle, internal oblique muscle, transverse abdominis muscle, and they all are positioned like this. Okay? पीछे एक दूसरे के साथ लगे हुए हैं. ठीक है, तो basically you're not able to see any of this, right? But because of the orientation, एक्सटर्नल ऑब्लिक ऐसे स्लांट जा रहा है, इंटरनल ऑब्लिक ऐसे स्लांट जा रहा है, ठीक है, एंड द ट्रांसवर्स एब्डोमिनस इज मूविंग लाइक दिस, ठीक है, द ट्रांसवर्स एब्डोमिनस इज गोइंग ट्रांसवर्सली. So this is the orientation that you have, right? So when you look at this, external oblique is going like this, internal oblique is going opposite direction, transverse is going this way. Now what I'm telling you is, you see this small area. There's a small area which is not covered by any muscle, neither by your internal oblique, I mean your internal oblique muscle, nor by your transverse abdominis muscle. ठीक है? This is your internal oblique, this is your transverse abdominis. It is not this small area, छोटू सा area ना, it is not covered by anything. So what is going to happen? Our friend is going to come. Who is our friend? Our friend is your fascia transversalis, which covers the entire area. Now as it covers the entire area, now anteriorly you have external oblique aponeurosis, posteriorly you have fascia transversalis. यहाँ तक clear है? अब देखो, I'm going to take everything out. This is going to be your external oblique aponeurosis, which is turned backwards, and as it has turned backwards, it is now formed into your inguinal canal, that is your superficial inguinal ring. This is your fascia transversalis, which is going to cover, which is going to be here. ठीक है? So now what we are going to do is, this is the posterior most layer, this is the anterior most layer. Now there is a small defect that is present in the fascia transversalis, and this small defect in the fascia transversalis, I'll just make the defect also. Now there is a small defect that is present in the fascia transversalis, and this defect in the fascia transversalis is what we call it as deep inguinal ring. ठीक है? अब इसकी जो ओरिएंटेशन है ऐसे है. When you look at this, this is how the whole orientation is going to be present. ठीक है? I'm just going to staple it so that it stays in its position. कितना काम करा रहे हो यार. Okay. Good. Now it is staying in its position. Great. Now as you can see, ठीक है, external oblique muscle or innermost is going to be fascia transversalis. External oblique में जो opening your fascia, I mean the inguinal ligament that is turned is formed as superficial inguinal ring, and this opening in the fascia your transverse abdominis or the fascia transversalis, sorry, is your deep inguinal ring. ठीक है? अब what is going to happen? Whatever structures are going to come, they're going to pass through it. What are the structures? ठीक है? Now, you know the vas deferens is going to pass. ठीक है? तो vas deferens की entry कहाँ से है? Vas deferens, let's say this is the vas deferens. ठीक है? Imagine this is the vas deferens. The vas deferens journey starts from the testis, goes up, enters into your superficial inguinal ring. As it enters into the superficial inguinal ring, ये अंदर चला गया. अब exit कहाँ से करेगा? It is going to exit from the deep inguinal ring. तो ये exit करता है deep inguinal ring से. It is going to come out like this. Now as it exits from the deep inguinal ring, it immediately takes a U-turn. ठीक है? एकदम flip करके U-turn मारेगा और peritoneum और इसके बीच में. So there's one more layer, no? What is the another layer? This is your fascia transversalis. Fascia transversalis के बाद कौन सा layer आएगा आपका? You have another layer, and this is your peritoneum. So you see the innermost layer that you will see here will be of the peritoneum. We will staple peritoneum also. Now let's say the innermost layer is the peritoneum. You flip the peritoneum, you see this is your fascia transversalis. The defect in the fascia transversalis is your deep inguinal ring, and this is the vas deferens which is exiting from here, and between the peritoneum, it is running between the peritoneum and the fascia transversalis, it goes. Now it is going to pop out from here. ये बाहर आएगा यहाँ से. ठीक है? Now when it comes out from here, it goes behind the bladder, combines with the seminal vesicle. Together they form the ejaculated duct, opens onto the prostatic urethra, and that is what we call it as verumontanum. That is what we call it as verumontanum. ठीक है? Clear है? Same thing which I have told you, I am going to draw and make you show. ठीक है? Everything remains the same. Nothing is going to change. We'll keep the same orientation. This is your anterior superior iliac spine. This happens to be your pubic tubercle. This is your pubic symphysis. This is your pubic bone, and this continues across here. There is no change in this. ठीक है? Now, as I said, we'll only draw the external oblique aponeurosis and the external oblique muscle. Now imagine this is the external oblique muscle. So this is the external oblique muscle that you have. This is the external oblique aponeurosis, which is combined here. So let's say this is the external oblique aponeurosis muscle, which is going to be here. So this external oblique aponeurosis, I'm just going to keep it open so that we'll be able to see what is happening. This external oblique aponeurosis, as it comes, it touches the pubic tubercle. As it touches the pubic tubercle, it is going to flip on itself. It is going to flip on itself, and this flipping on itself is going to give you your superficial inguinal ring. ठीक है, तो ये आपका superficial inguinal ring बन गया. ठीक है, this is your superficial inguinal ring. I am taking out the internal oblique transverse abdominis. I'm only going with fascia transversalis. Now imagine that this is the fascia transversalis that is present. Okay? So the innermost layer that you have, which is here, is going to be of the fascia transversalis. Now the fascia transversalis that is going to be present, there's a small defect in the fascia transversalis, and that defect of the fascia transversalis is what we call it as a deep inguinal ring. So there is a genuine defect that is present in the fascia transversalis, and that defect of the fascia transversalis is what we call it as a deep inguinal ring. So I've just taken out everything so that you'll be able to see only the external oblique aponeurosis and the fascia transversalis. Okay? Just for the sake of understanding, this is your external oblique muscle. Right? You are only able to see. So I've just taken out. This is the transverse. There is a fascia transversalis. Okay? So this is your fascia transversalis, and a defect in the fascia transversalis is going to be your deep inguinal ring. The defect is going to be your deep inguinal ring, and bang on, this is the defect that is present. Now it's basically there is no canal, है ही नहीं कोई canal. होता क्या है, यहाँ से एक चीज एंटर करती है और यहाँ से एक चीज एग्जिट मारती है. ठीक है, एंट्री यहाँ से, एग्जिट यहाँ से, उसी को आप इंग्वाइनल कैनाल बोल रहे हो. सो व्हाट इज हैपनिंग इज द वास्ट डिफरेंस स्टार्ट्स इट्स जर्नी, गोज हियर, enters into your superficial inguinal ring, travels across here. So let's say I'm just going to show you the travel, which is going to be in a dotted line, travel, 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 and then it goes into the deep inguinal ring, flips it back, and then travel, and then exits behind the bladder. Now this passage through these charted planes is what we call it as inguinal canal. तो अगर इतना समझ में आ गया ना, तो इंग्वाइनल कैनाल की एनाटॉमी कभी भूलना ही नहीं. ठीक है, इंग्वाइनल कैनाल का जो एंटीरियर सरफेस है, एंटीरियर बॉर्डर ऑफ द इंग्वाइनल कैनाल इज फॉर्म बाय एक्सटर्नल ऑब्लिक अपोन्यूरोसिस. इंफीरियर बॉर्डर ऑफ द इंग्वाइनल कैनाल इज फॉर्म बाय एक्सटर्नल ऑब्लिक अपोन्यूरोसिस. द पोस्टीरियर बॉर्डर इज फॉर्म्ड बाय द फेशिया ट्रांसवर्सालिस. खत्म. What is your superficial inguinal ring? It is basically a U-turn of your external oblique aponeurosis. What is a deep inguinal ring? It is a defect in your fascia transversalis. ठीक है, is that clear? ठीक है, आगे चल के कभी गलती नहीं करना. Sorted है. Is everybody clear? Quick feedback. ठीक है. अच्छा, honestly बताना, do you think this worked? This analogy that we did today, do you think it worked? Because see, I draw well, so I take a lot of pride in my drawing. So I could have explained you with the drawing also. So what do you think? Is it like drawing was better or this was better? फिर से boundaries, ठीक है, देख लो यार, boundaries ही boundaries है, कोई दिक्कत नहीं है. We'll make it very simple. ये जो बाहर वाला है ना, ये एक्सटर्नल ऑब्लिक मसल है, वही एक्सटर्नल ऑब्लिक अपोन्यूरोसिस की तरह हो गया. एंड दिस एक्सटर्नल ऑब्लिक अपोन्यूरोसिस व्हेन इट टर्न्स बैकवर्ड्स, तो ये अपने ऊपर फ्लिप कर रहा है ना, पीछे की तरफ फ्लिप मार रहा है. यू कैन सी ये जो है ना, ये पीछे की तरफ मुड़ रहा है. यू कैन सी द रेड वन, इट इज टर्निंग बैकवर्ड्स. ठीक है, तो ये फ्लिप को आप क्या बोलोगे? दिस फ्लिप इटसेल्फ इज व्हाट वी कॉल इट एज द सुपरफिशियल इंग्वाइनल रिंग. अगर आप बाउंड्री देखोगे, एंटीरियर बाउंड्री ऑफ द इंग्वाइनल कैनाल इज फॉर्म बाय एक्सटर्नल ऑब्लिक अपोन्यूरोसिस, inferior boundary is formed by external oblique aponeurosis, the posterior boundary is formed by fascia transversalis. This is your fascia transversalis. The defect in the fascia transversalis, the defect in the fascia transversalis is what we call it as deep inguinal ring, and this U-turn that you have created is what we call it as superficial inguinal ring. तो यही है, superficial inguinal ring is basically a combination of your external oblique aponeurosis which is turning you. So it's basically a defect in external oblique aponeurosis. What is deep inguinal ring? It is a defect. It is a defect in fascia transversalis. क्लियर है? ठीक है. नाउ इफ यू वांट टू बी प्रिसाइज, जस्ट यहाँ पे आपका एक और मसल आ जाएगा. व्हाट इज दैट मसल? दैट इज इंटरनल ऑब्लिक. इसके पीछे एक और मसल आ जाएगा. दैट मसल इज गोइंग टू बी योर ट्रांसवर्स एब्डोमिनस, एंड इसके पीछे आपका फेशियल ट्रांसवर्सालिस है. बात खत्म. ठीक है. सो दिस इज व्हाट यू शुड नो. क्लियर है? चलो. So if you've understood this, now this is the basic orientation of the inguinal canal that you need to know. Now what we'll do is we'll now simplify the inguinal canal for our understanding, right? So I'll just make a simplified model. Simplified inguinal canal. So whatever discussion we're going to have on inguinal hernia will be on the basis of the simplified inguinal canal. अब ये simplified inguinal canal क्या है? This is going to be your inguinal canal. So ये this is going to be your superficial inguinal ring. ठीक है. So this is the anterior border. ठीक है. Posteriorly, what do you have? Posteriorly, you have the fascia transversalis. The defect in the fascia transversalis is what we call as deep inguinal ring, and it is going to continue. Right. Above this, what do you have? Above this, you have the peritoneal surface. So this is the peritoneum. Inside this, you have your bowel. So this is your intra-abdominal content. So this is your intra-abdominal content that is going to be present. Okay? So this is inside the abdomen, right? So what are the layers you have? The innermost is going to be peritoneum. Then this is your fascia transversalis. This is going to be your fascia transversalis. This is your deep inguinal ring. Now, deep inguinal ring is going to be in an inverted U shaped. This will be an inverted U shaped. This is a deep inguinal ring. This is your external oblique aponeurosis. This happens to be your superficial. This happens to be your superficial inguinal ring. This happens to be your superficial inguinal ring. Now, when you look at this, what is going to pass through this? You see the, if you look just for the sake of understanding, let's say this is the testes, right? You will notice the vast difference from the testes will arise. It will go into the superficial inguinal ring. It will go into the inguinal canal. It will exit the deep inguinal ring, take an immediate U-turn, and follow, or it will flow between the peritoneum and the fascia transversalis. Where is it going to go? Now you take this as the representation of the bladder. Let's say this is the ureter that is present. And there's a gland that is going to be present here. This is your prostate gland, right? So let's say this is the prostate gland that is going to be present here. Now this prostate gland will have a seminal vesicle. So I'm just going to erase the superficial inguinal ring. ये थोड़ा disturb कर रहा है. So let's say this is going to have a seminal vesicle here. So let's say there's a seminal vesicle which is present here. This is the seminal duct. So what is going to happen? The vast difference is going to come, go behind the bladder. It is going to come, enter behind the bladder. It goes behind the bladder, and then together it is going to combine with the seminal duct. Together they form the ejaculatory duct, goes through the prostate gland, opens into the prostatic urethra, and the opening in the prostatic urethra is what we call it as verumontanum. This is what we call it as the verumontanum, and this is the journey of your vas difference. Along with that, there is a nerve that is going to travel. The nerve that is going to travel along with this is going to be the ilioinguinal nerve. So when you say what is the content, right? This is your superficial inguinal ring. The content of the inguinal canal is going to be vas difference in males and round ligament in females. And the nerve that is going to be present here is going to be the ilioinguinal nerve. It is going to be the ilioinguinal nerve. This is going to be the ilioinguinal nerve. Okay? So these are the content of inguinal canal. So from tomorrow, when we talk about the clinical presentation of the inguinal hernia, what is the difference between direct and indirect inguinal hernia, all that, we'll be using only this small sketch diagram to answer all our questions and queries. Clear? Sorry, right? So if you have understood, thank you so much for joining today. We'll resume back tomorrow at 9 o'clock again, and we'll continue our inguinal hernia. So tomorrow we'll talk about the difference between direct and indirect inguinal hernia, clinical presentation, clinical examination of hernia. That is what we're going to cover, all that. Okay? Clear, guys? Chalo. But Furre series lectures are going to be precise, crisp, for your university exams. So Furre mein, I'm trying to teach you that when you approach a question in an exam, if it's a 3 mark, 5 mark or a 10 mark, how much to write, what to write, and what is the performer that you have to maintain. So wahan pe na zyada explanation nahi milega. You won't find much of explanation in Furre. You will see only how an answer is going to flow. This, on the other hand, is going to go to the core of the every single topic to address the basic concepts. Okay? Chalo. Ashutosh, it's a promise that we have made on the first day of BLS कि पूरी बेली YouTube पे पढ़ा देंगे, पूरी बेली. ऐसा कोई पन्ना नहीं होगा, ऐसा कोई पेज नहीं होगा जो हम बेली का छोड़ेंगे. We will run this series as long as the Bailey does not finish. The day we finish the last page, last chapter of Bailey, we will all celebrate. But every single lecture, I will try to improve it as we go further and further. But we'll make sure that we finish the Bailey here. Now, this is like, no, it's very close to my heart. I wanted to start the series because I just wanted surgery to be available for everybody. I wanted everybody to read Bailey. I wanted everybody to understand. So this is an effort from my side so that I can contribute a bit to our surgical education. Thoda mere liye bhi selfishness hai. And I would, this is like my baby. I will nurture BLS until we finish the entire Bailey and Love. Okay? We'll do that. And it will be free. It will be on YouTube. It will have all the series. We'll make sure every single thing sits in here. There is no if and but on that. Clear? Chalo. Thank you so much, guys, for joining today. We'll resume tomorrow at again 9 o'clock. Tomorrow we'll do it much more better. I'll bring in more props tomorrow to make you understand hernias. See, when the GIT starts, no, you will see a lot of these. Like what we did for hernia, no, the whole GIT is going to be in that journey. Okay, I'm really excited to, go on a daily basis. Hopefully, I have enough amount of energy to kick it and make it happen. Thank you so much. Love from Nepal. Thank you so much, guys. Right? Thank you so much. I mean, your words of appreciation means a lot. I mean, like, when the chat box is buzzing. I still remember when we started, the BLS series, we hardly had initially 5 or 10 students. Now we have a continuous attendance of at least 20-30 students which watches live, right? And as we go, I just want the series to grow. I want, there should be a day where you have hundreds of thousands of you watching on a YouTube live free, and that to a surgery session will be a dream come true, right? Thank you so much. If you feel, this is like a really good series, do recommend your friends, ask them to come see, watch it. If they find it better, let's make a trail out of it. Okay? Chalo. Thank you so much. And we'll resume back tomorrow at 9 o'clock. All right? Until then, good night. Take care. Bye-bye.